Okay, it's 5:05. Ejabere.
So I think we can start now. We have
Yes,
a
sir.
good number of people.
Yes, sir.
Okay. Good evening, everybody. We are welcome today to another clinical conference, and hope the day has not been too busy. And thank you for joining us again today for this clinical conference. Today, I'm wearing two hats. I'm the speaker and also the moderator, and hopefully other colleagues will join as we go on in the presentation. And today we will be looking briefly, it's going to be a short presentation, and we are going to be looking at how to evaluate patients with bradycardia. Bradycardia is one of the clinical conditions we encounter almost every day in the clinic, in our various clinics and clinical practice. And the aim of this presentation is that at the end of the day, we'll be able to have an idea how to review a patient with bradycardia, what we need to do, at what point do we need to send them to the cardiologist? Is it every patient with bradycardia that has a pathological condition? And do we need to be afraid anytime we see a patient with bradycardia? And today, as I start, let me say we're going to do a little bit of ECG as we go on, but believe you me, it is going to be something easy. I'm not going to scare you with difficult ECG, just basic thing for us to understand what we need to see when we are reviewing a patient with bradycardia. So we're going to go through brief introduction about arrhythmia, look at cardiac conduction system, then go into looking into patients with bradycardia, what are the causes, how do we evaluate them, and just a little mention of treatment. So arrhythmia generally is when we are talking about arrhythmia, we're talking about abnormality of the rhythm of the heart and sometimes abnormality of the heart rate, or simply saying when a patient does not have a normal sinus rhythm. And what is a normal sinus rhythm? As we know that the SA node is the principal pacemaker of the heart. And so a normal heart rhythm is produced by the sinus rhythm, and it moves through the interatrial fibers and other fibers to the left atrium, both atrium fully depolarized, and the impulse moves to the atrioventricular node, where there's a small pulse that allow for full depolarization of the atrium before it goes down through the AV bundle into the left and right bundle branch and ending in Purkinje fiber that supplies that carries the impulse down to the ventricles. So when there is any abnormality along this line, then what we have is what we call arrhythmia. And broadly speaking, we can categorize into the fast abnormal heart rhythm or the slow abnormal heart rhythm. The slow abnormal heart rhythm is what we call bradyarrhythmia, under which the bradycardia we're talking about uh, comes up, and we have the tachyarrhythmia, where you have fast abnormal heart rhythm. For example, the atrial fibrillation we talked about last week falls under this category. And generally, when we are talking about abnormality of the heart rhythm, it's generally under two categories. We're talking about problem with the initiation or generation or formation of the impulse, or there is problem in the conduction or the transmission of the impulse. So it's like talking about power generation. So it is either there is problem from the grid is not producing enough power, JPS is not producing enough power, or JPS is producing enough power, but there is problem along the transmission line. Maybe the wires are not good, or maybe something is blocking the power from leaving the generation point up to the endpoint where the power is needed. And like I said, looking at the conduction system of the heart, the SA node is the dominant pacemaker of the heart. And the SA node is located at the junction of the superior vena cava and the right atrium. So these are a group of cells, myocyte cells, that have this intrinsic ability to generate impulse. And once these points generate their impulse, there is a sort of override suppression that pulls every other place to rest so that the heart can work in an organized fashion, in an organized way, that the impulse flows from the sinus node across the atrium to the AV node and down the line. So, like I said, they're just a group of um, cells are located around that area. The blood supply is important because when we talk about the causes, we will be able to relate how problem with blood supply, with coronary circulation can affect and lead to bradycardia. So the SA node is mainly in about 59% of the population is supplied by the right coronary artery, and in about 30%, the left circumflex artery is responsible for supply for blood supply to the side SA node, and in 3% of patients, they take their supply from both the from the right coronary artery and the left circumflex. And like I said, the SA nodal cells, they have this fast intrinsic rates and making them to be able to depolarize very fast. And if we remember our physiology, the SA node is where my pointer is. They don't have a true resting potential. So after the phase 3 depolarization, which is due to influx of potassium, and once the membrane potential of the cell gets down to about -60, the Fonny current opens, allowing potassium to sodium to enter into the cell. And once the membrane potential gets to around -50, you have the opening of the transient calcium gates. Then by the time you reach the threshold potential around 30 millivolts, then you have the opening of the long calcium gates, which allow influx of calcium that is responsible for that slow depolarization phase of the SA node. And when you compare that SA node to other cells in the myocardium, in the AV node, you will see that other cells, they have a true resting potential. So this gives the SA node the ability to quickly depolarize, generate the impulse, and that overrides other AV node. But we should note that when there is problem with the SA node, other area like the AV nodes, the East bundle and the Purkinje fiber also have that innate ability to be able to generate impulse, but doing so at a relatively slower rate compared to the SA node. So you have the SA node at the junction of the superior vena cava and the right atrium, generating the impulse and going along the pathway, like I said. So you will have abnormality resulting in bradycardia or anything when there is problem within the SA node, not able to generate the impulse, or you have a block either from the exit point of the SA node, or you have what we call conduction abnormality when you have problem in the AV node or along any of this line. And that is what we're mainly going to be talking about this evening. So it's just the same thing that I've showing us how the impulse are generated and going down up till you get to the Purkinje fiber where the ventricles are depolarized. So trying to look for a prevalence of bradycardia in the Caribbean was difficult. Most of the studies seen were institutional-based study, and many of them actually looked at the number of pacemaker inserted. So it was difficult getting a generalized prevalence of bradyarrhythmia in the Caribbean. But I got this from the UK Biobank, which is a population-based prospective cohort that looked at about 500,000 adults over average of seven years. Both male and female, but over 90% of the population studies were whites. Very less than 10% black population were included in the studies. And when they look at them at the baseline rhythm abnormality, there's about 2.3% baseline rhythm abnormality. And from the rhythm abnormality, like we were told last week when we were looking at atrial fibrillation was the commonest abnormal heart rhythm identified, followed by bradyarrhythmia. Under the bradyarrhythmia, you have the bradycardia and the conduction abnormality. And they also looked at them, like I said, over the average of 7 years, and they discovered about 15,900 new rhythm abnormalities were detected in among them. And atrial fibrillation still came on top, followed by bradyarrhythmia. And this is showing what I talked about, both at the baseline and new abnormal heart rhythm that developed along the way. Still more of atrial fibrillation, followed by bradycardia and conduction abnormality, then followed by other type of abnormal heart rhythm. And so if we generally define what bradycardia is, I know right from medical school, we've always talked about heart rate less than 60 beats per minute, but significant bradycardia is defined as heart rate less than 50 beats per minute. But nobody will fault you if you also say heart rate less than 60 beats per minute. And bradycardia may be physiologic in some group of people, in well-conditioned athletes, in young people, old people, and during sleep. These are not due to any clinical pathology. But even when you find bradycardia in this group of patients, it is still important for you to evaluate and investigate before you conclude that you are dealing with a physiological type of bradycardia. And for the pathological bradyarrhythmia, you have to look at the causes. Some causes are extrinsic, some causes are intrinsic in the heart, some causes are reversible, and some causes are irreversible. And like I said from the beginning, that I just want to show us just two things from the ECG so that you just have an understanding of what we are talking about. And two things I want you to look at. Forget every other line and whatever. I want you to look at these two tall guys there, the R wave. I want you to look at the two of them so that you look at the interval or the time between them. And normally, the interval between the two R interval for a normal sinus rhythm should not be more than 5 big boxes. So when you see one tall guy this way, the other tall R wave, and you look in between them, the number of big boxes in between them should not be more than 5. Once it is more than 5, you know you are dealing with bradycardia. The heart rate is slow. Then the other thing I will want you to look at is also to look at the P wave. That's the first positive deflection you see on your ECG, and the QRS complex. So the time between the beginning of that P wave and the beginning of the QRS complex is what we call PR interval. And ideally, that PR interval too should not be more than 1 big square. Just those two things I want you to know for the purpose of this presentation. Every other thing, we will learn it later. And so, for you to know whether your patient has bradycardia or not, at least you should be able to know what the heart rate is. And like I said, you are just looking in between the two tall wave on the ECG, that is the R wave, and looking at the number of B square. Forget any other thing you've heard somewhere for the purpose of this presentation. And you just want to count the number of B square between the R wave. And like I said, once you have more than 5, then you are dealing with bradycardia. And at least I have one simple exercise for us to do. If you look at the one above, which I call the normal sinus rhythm, like I said, that is the rhythm coming from the SA node and going through the normal conduction pathway. So if we look at these first two R wave, if you just count briefly, this is let's say 1, 2, 3, 4, and stuff like that. Like I said, if it is more than 5, that is slow heart rate. Like I said, this is not up to 5, but if we look at the one below, if we count 1, 2, 3, 4, 5, 6, 7, this is about 7. So if you look at this is definitely less than 60 beats per minute, because what you do is to divide 300 by the number of the big square between the two R waves. So 300 divided by the number of big boxes between R waves. So I said the one below is 7. So if we divide 300 by 7, that's 7 times 7, 300 by 7, 7 times 4 is 20. So we're saying the heart rate for this strip below is about 40 something, which is far less than 50 beats per minute that we took as our cutoff for bradycardia. So if you have an ECG like this, you have made your diagnosis of bradycardia in that patient. And so once you have a patient with bradycardia, like I said, 2 things you really want to ask yourself: where is the problem? Is it from the JPS point of generation of the impulse, or is it along the line of conduction? So when you are dealing with problem that has to do with impulse formation from the SA node, then the patient has a sinus node disease. And if it is about transmission, then the blockage or inhibition of transfer of the impulse along the pathway, then it could be blockage from the SA node level, or block at the level of the AV node, or as you go down along the bundle of ease or along the bundle branch, either the left bundle branch or right bundle branch. So you have a patient presenting to you with bradycardia or symptoms that you think is related to bradycardia. Just ask yourself that 2 questions. Do I have problem from the point of generation, or is it the transmission problem that I'm facing? And when you're looking at transmission problem, you look at it from different level, whether from the SA node, whether from the AV node, or whether down. But for the purpose of this evening, we will limit ourselves to issue with the sinus node and the AV node. We will not talk about the bundle branch block. We will not talk about other positional induced bradycardia for the purpose of this presentation. So when we're looking at the problem with sinus node, most of the time it is due to disease of the sinus node or the surrounding tissue, and most of the time it could be due to fibrosis, it could be due to ischemia, due to problem of blood supply, maybe from coronary artery disease, or it could be due to infiltration from other conditions. We'll talk about sarcoidosis, amyloidosis, and stuff like that. And when this happens, then there's problem with impulse formation from the SA node, and it's going to manifest in different ways that we're going to look at shortly. And I hope we're able to see this table. Like I said, it's going to manifest in different ways. Number 1 is patients may manifest with just the heart rate less than 50 beats per minute. That is what we call sinus bradycardia, like I said. Other way is the impulse could be generated, but there is a block for the impulse to leave the SA node. That is what we call the sinoatrial exit block. The impulse generation is going on, but the impulse cannot just leave the SA node. Then the sinus node arrest, there is no impulse formation at all. Both SA exit block, sinus node arrest, most of them on the ECG, most of them will show as a sinus pulse, because I will show us the ECG. You will just get to a point where you don't see anything happening, because it is either the SA node is not generating the impulse, or the impulse is being generated, but the impulse could not exit the SA node to get to the other part of the heart. So it just seems as if nothing is happening. Then other way that sinus node dysfunction can manifest is what we call the tachycardia bradycardia syndrome. What happens is that you have alternating arrhythmia followed alternating fast heartbeats, whether regular or irregular. It could be atrial fibrillation that is now followed by period of sinus arrest or sinus pause. So you see a patient having atrial fibrillation, then after that you just see a long line of no activity on the ECG before the ECG picks up again. That is another way you can suspect that there is problem within the sinus node. Then the next way that you can also suspect a patient has sinus node dysfunction is when there is chronotropic incompetence. The meaning of this is, when we are exercising, the heart is supposed to be able to increase its rate, its function, to be able to supply the amount of blood commensurating with the need of the body to increase the heart rate to match up with the level of activity at that point in time. But when there is problem with the sinus node, what happens is the heart is not able to do that. The heart is not able to move the activity to match up with the level of the exercise that is going on. And this is practically defined as when you cannot achieve 80% of the expected heart rate during the period of exercise, then you say the patient has chronotropic incompetence. Then there could be other way, but these are the major way you see a patient with sinus node dysfunction presenting. And this is just looking at what I've talked about. I talked about the sinus bradycardia. Then you have a sinus pause that I said could be either be due to sinus arrest or a block. And what you have is you have the P wave with the Q arrest, then you have a long period when it seems the heart is silent and the heart has stopped. And once it is more than 3 seconds, that becomes very, very, very significant. And I also talked about the tachybrachia syndrome. You have period of tachycardia or atrial fibrillation that is followed by period of a pause, and the heart picks up again. Then, if the problem has to do with AV block, where you the AV node, where you have a sort of block that prevents the movement of the impulse from the atrium down to the ventricle, then you face different type of atrioventricular block from the first degree to the second degree and to the third degree. And there's a simple and easy way we looked at the AV block, and we call it the story of AV block family, where the P wave is the wife and the QRS is the boyfriend or the husband. So for a normal sinus rhythm, the P wave is there at home, and the husband, the QRS, comes home regularly at the same time every day, and everything is going on smooth. In first degree AV block, what we have is there is prolonged PR interval from the first image I show us. So the PR interval, that is the time from the beginning of the atrial depolarization to the beginning of the depolarization of the QRS complex, that I said should not be more than one big box, is prolonged, but the impulse goes on. So what happened is the P wave is the wife is at home, and the husband comes home late every time, but it will come, and it will always come at the same time. So the PR interval is prolonged, but is constant, and it comes like that every time. This is what we have here. So we can see from the beginning of the P wave here, and the QRS is bigger than one big box, but you will find out that it is the same every time. So the boyfriend always comes home every day. In second degree AV block type 1, or what we call Mobitz 1, what we have is there is progressive increase in the PR interval until we get to a point when there is a P wave and there's no QRS, and the cycle starts again. So what happened in type 1 of the second degree AV block is the wife is waiting at home, and the boyfriend comes home later and later every day. So the first day, the guy comes at 9 p.m. The second day, he comes at 11 p.m. The third day, he comes at 12 midnight. And the fourth day, he just decided, what's the stress? Let me just stay out. So the PR interval continues to increase until it gets to a point that the guy just refuses to come. Then the cycle starts all over again. That is the second degree type 1. In the second degree type 2, the PR interval is constant, but it just gets to a point that the guy refused, that just decide, I'm not coming home again. So the wife is at home, and sometimes the husband just decided to come. But anytime he comes home at the same time. So the PR interval is constant until you get to a point when you have a P wave and there is no QRS complex. And by the time you get to the third degree, there's total chaos. The relationship has totally broken down. The wife is on his own, the P wave is doing his own, and the QRS is doing his own. There's no relationship between the two, and everybody has gone their own way. So that is what the AV block looks like on the ECG. And we will know which of the AV block really needs clinical attention at one point or the other. So when you look, like I said, when you look at this, you know, okay, what am I dealing with? Am I dealing with a sinus node disease, or am I dealing with problem at the level of the AV node and facing AV block? And so how do I approach this patient? The first thing that is important is to take a good history. Like I said, you want to see, is this a physiological problem? You want to know whether a patient has symptoms. And when you are looking at symptoms, you are looking at the frequency of the symptom. You want to look at the severity of the symptoms. You want to be able to match the symptoms with the level of activity of the patient. Then, after doing that, you want to take a history to rule out reversible causes, whether the patient is on medication, whether the patient is an athlete, whether the patient has many other conditions that could affect both the sinus node or the AV node before you go on to family history. There are some genetic conditions that could affect the channels in the heart, the ion channel that I talked about when we're talking about the action potential that could result in some hereditary problem leading to bradycardia. And from that, you want to examine the patient you want to count the pulse, you want to examine the heart, listen for murmur, and look out for other clinical points that can point to any of the underlying cause. And definitely you must do an ECG. You want to see what you have on your hand and do appropriate cardiac imaging. This forms the basis of review of your patients. So like I talked about, so you want to look at the symptoms, and some of the symptoms I listed here. So patient having syncope, your patient is fainting, pre-syncope, patient has lightheadedness or dizziness. Some may just come with extreme fatigue, shortness of breath on exertion, like I said, because of the chronotropic incompetence, the act could not match up with the level of activity. So they run out of breath, they become, they get tired easily. Then some may present with heart failure symptoms. And due to hyperperfusion, some may also present with confusion, memory loss. And we should not forget, some of these patients can actually present to you with palpitation. And somebody just tell you that I just feel like a thump in my heart very slowly, and I feel tired, I feel dizzy, and it's like I just don't have any strength in me. And like I said, some of these patients may even present like a patient with ischemic heart disease, with chest pain, diaphoresis, and stuff. And by the time you examine, you find that the pulse rate is so low, it's so slow, especially patients with inferior myocardial infarction, where you have the involvement of the right coronary artery. And like I said, that RCA supplies the SA node and the AV node in about 59% of patients. So when you have that, the main presentation for some patients may just be bradycardia weakness, and by the time you do your ECG, you start seeing all the other changes. Then you need to, like I said, ask questions about medication, which is one important reversible cause that we need to rule out. Then other questions. So, like I said, these are just we'll just look at some tables listing common drugs that could present with bradycardia, affecting both the sinus node and the AV node, beta blockers. So propranolol, atenolol, Concor, carvedilol, metoprolol, our non-dihydropyridine calcium channel blocker, verapamil, diazepam. So most of our anti-arrhythmic drugs, amiodarone, all of them, patients on adenosine or digoxin for heart failure, you should be on the lookout for them. So you just don't forget, just write your 0.25 milligram of digoxin for 1 year, 6 months. You are not checking the pulse rate, you are not looking at the ECG. So a lot of our medication, antidepressants, anti-epileptic medication, muscle relaxants, our proton pump inhibitor, pantoprazole, omeprazole, all of them. There's so many of them. Chemotherapeutic agents. So all these are medication. So when you're taking your history, you must take an extensive drug history from the patients. Then the intrinsic causes, like I said, family history will help here. History of any genetic disease, cardiomyopathy, take a history about anything else, any history or symptoms suggestive of ischemic heart disease and infiltrative heart disease. All these you must look into, because you actually will not know until you ask this patient. Then this thing can also occur following our CABG for our surgeons, after TAVI for aortic valves procedures. So this for this group of patients after CABG, after TAVI, we must observe them, follow them up, look at their ECG to make sure that they don't come back to us with sinus node dysfunction or significant AV block. And we should not forget electrolytes too, both hypo and hyperkalemia, hypercalcemia, hypermagnesemia, patients with hypothyroidism. And that is why every patient with palpitation, whether tachyarrhythmia, bradyarrhythmia, your thyroid function test must be a major part of your investigation. And we should not forget patient with head injury with increased intracranial pressure, and they can have that triad. I forgot the name now. And we talked about sleep apnea, I think 2 weeks ago. So sleep apnea is one of the major conditions that we also need to look about, because we talked about significant bradycardia during sleep, and some patients also have significant bradycardia, significant AV block when they are sleeping. So, and this is where it is important for every patient with bradycardia, with tachyarrhythmia, to do Holter ECG, because apart from looking at the heart rhythm, it is only from your Holter ECG that you could actually pick a patient having sleep, having significant bradycardia, significant AV block during sleep. And that group of patients, you need to do a sleep study for them, and just giving them CPAP to treat the obstructive sleep apnea may just be enough to take care of them. And from that, the bradycardia and the AV block may resolve following that. And that is one of the important reversible cause. Then after your history, you do your physical examination, like I said, to look for things that could point to some underlying cause. Then from there, we go to non-invasive evaluation, and the number one and the most important is your REST 12-lead ECG. And the ECG here is for one of our patients, a 60-year-old woman that presented with history of recurrent syncope and recurrent falls, weakness, and she has a background history of hypertension. She's been hypertensive for about 20 years, and she also has history of hypothyroidism. She has significant family history of heart disease. And when she came to us, she had gone to the public hospital, and the ECG that was from the referral letter, what was written there was that on the ECG, she had a complete heart block, and the heart rate was about 35 beats per minute. And she came to us, and when she came to the clinic, this was the first ECG that was done. And on that day, our assessment is of a second degree type 2 AV block, where I told us that the PR interval is constant, and you just have a P wave that is not conducted. And that's what we saw in this patient. Forget every other thing. Like I said, the heart rate here, if we count between the two tall guys, the R wave, this is 1, 2, 3, 4, 5, 6, 7. So if we divide 300 by 7, we're looking at 40-something beats per minute, which gives us our definition of bradycardia. And then you now look at the relationship between the P wave and the QRS complex. And after the ECG, like I said, sometimes you may see this patient at the first point of contact, the ECG might actually look normal, and the patient came to you with complaint of syncope, tiredness, dizziness, lightheadedness. So you may have to go beyond just the REST ECG. And what you do now depends on the frequency of the symptoms the patient is having. So for those having daily or frequent symptoms, our regular Holter, we do. And you can, and for people having infrequent symptoms, external loop recorder down to internal loop recorder could be used, so that the changes on the ECG could be picked. And like I said, apart from making the diagnosis, the Holter ECG, the ambulatory ECG, also help us to be able to correlate symptoms with the changes on ECG. And also, that also gives us the opportunity to be able to get them during sleep to see if they have sleep apnea-induced significant bradycardia or sleep apnea induce significant AV block. So those are some of the extra things you get when an ambulatory ECG is done. And for those with chronotropic incompetence, like we said, you need to do an exercise test in them. They need to do a stress test, because that is the only way you can identify whether patient has chronotropic incompetence or not. So we need to put them on the treadmill, attach an ECG, monitor their blood pressure, monitor their heart rate, and see what goes on. And you see whether the patient is able to get up to the 80% of the target heart rate that is calculated based on the age of the patient. And for patients with significant bradycardia, they need to have an echocardiogram done. Echocardiogram, major imaging that you need to do for them. Other cardiac imaging now depends on the presence of other secondary, other underlying pathology, but the basic imaging you need to do for them is echocardiogram. So other image, MRI, CMR, now depends on the other underlying condition. And like I said, the laboratory test, very important. The target function test, all the electrolytes you need to do. And if you have ability to measure digoxin level or the lime titer to rule out other underlying cause or medication toxicity, you can also do that. And genetic testing where the facilities are available. And like I said, screening for sleep apnea is extremely important, especially in the presence of severe bradycardia and advanced AV block during sleep. And like I said, just taking care of the sleep apnea may be enough to take care of these patients, because like it's in one of the study about 40% of patients with sleep apnea can have significant sinus bradycardia, and about 30% of patients with sleep apnea can present with advanced AV block, that's second or third degree AV block. And treating the sleep apnea with CPAP can give you positive results in about 90% of these patients. So this is one of the reasons, again, saying it again, why Holter ECG is very, very important. And like we know, in patients that present with syncope, it is not only bradycardia. You can have orthostatic hypotension, neurocardiogenic syncope as close differential in this. So these patients also might need to do a tilt table testing to be able, for you to be able to rule out port syndrome, neurocardiogenic syncope, orthostatic hypotension in them. And we've talked about loop recorder when you have infrequent, and putting everything together. So for those having symptoms during sleep, they need to do a sleep study. In young patient that has family history of heart disease, if you have the capacity, you need to do the genetic testing. If you are suspecting electrolyte derangement, definitely your laboratory tests come into play. If you are thinking it could be sarcoidosis, amyloidosis, then you need further imaging after echo. So MRI, CMR, that needs to be done. And like I said, for those that have positional induced syncope, tilt table testing, carotid sinus massage, and for those with exercise-induced symptoms, your exercise test comes into play. And by the time you do all this, you'll be able to place your patient, whether your patient has a sinus node disease or due to AV block. And just looking overview of treatment, because like I said, this lecture is not really going to deep, just to give us an overview of the causes and how to evaluate. If you are able to identify reversible causes, that should be treated. Pacemaker should not be inserted for patients with reversible causes. So if it's medication, hypothyroidism, hypokalemia, hyperkalemia, those should be treated. And for those with irreversible causes and advanced AV block, they should have a pacemaker inserted, pacemaker with different mode, with different programming. And as also you are doing this, comorbid condition, coronary artery disease leading to bradyarrhythmia, heart failure, infiltrative disease, all those conditions should also be managed along. So this table from the AHA is just talking about the medical treatments for reversible causes, mainly those that are due to medication overdose. So from patients with calcium channel blocker overdose, you can give them calcium gluconate, calcium chloride. For those with beta blocker, you can use glucagon or high-dose insulin. From those with digoxin antibody fragments. And then for patients with symptomatic sinus bradycardia or AV block, your atropine, epinephrine, those comes into play. We actually did this, I think, last week when we had a patient that came in with significant bradycardia, syncope after taking, I can't remember the drink that the patient took, and the artery just went down, and she was just blacking out. So we had to give atropine. We give about 2 doses, and the patient actually had to be put on temporary pacemaker over the night. And by the second day, I think when the stock cleared from the system, the heart rate came up and the patient became well. And patient actually went home. We took her off the beta blocker she was on, and she has been fine, and she has come to the clinic at least for follow-up after that. And then for patients with sinus node disease, like I said, with symptoms that can be attributed to that, the patient needs to have pacemaker. Sinus node dysfunction, patient needs to have pacemaker. 3rd degree AV block, with symptom or without symptom, the patient needs a pacemaker. 2nd degree type 2 AV block, symptoms or no symptom, the patient needs a pacemaker. 2nd degree type 1 AV block, only symptomatic patient with 2nd degree type 1 AV block needs a beta blocker. So I think that is clear. 3rd degree, 2nd degree type 2 AV block, symptoms or no symptoms, the patient needs a pacemaker. 2nd degree AV block type 1, the patient needs to have symptoms before you can consider a pacemaker. For 1st degree AV block, it's a benign condition, but patients with symptom and significant 1st degree AV block, pacemaker may also be considered. So that is the summary of pacemaker for those group of patients. Then I just want to add this: for patients with significant AV block and heart failure, what they should have is what we call a CRT, that is cardiac resynchronization therapy, and not a pacemaker. And the difference between that is in cardiac resynchronization therapy, both ventricles have wires inside them, but for pacemaker, the wires is inside the right ventricle alone or inside the right atrium and the right ventricle. But for patients with cardiac resynchronization therapy, you have wires in the right atrium, right ventricle, and behind the left ventricle, so that we can coordinate the activity of both ventricle at the same time. And this was the patient I was talking about the first time. So this was the same ECG that I showed us at the first contact. So we canceled the patient, put her on Holter ECG, admitted her, and on our Holter ECG, we saw all sorts. We saw this The same thing we saw in the clinic, then there later progressed to what we call high-grade AV block. Because what you see initially is you see a PQRS, you see a P wave, no QRS, you see, but along the line, you see advanced high degree. And what we mean by high degree is you have numerous P wave that has no QRS. So you just see the atrium, nothing, then one, then. So showing us that the patient can present to you just with normal ECG, just simple sinus bradycardia. It may be more than that, because you don't know what happens at the period when the patient is having syncope. And so here now we can see that the patient has very advanced heart block. And later we also saw premature ventricular complex, and the patient was advised cancelled, and she had a dual chamber pacemaker. And this is the ECG post pacemaker insertion. And the patient has been doing fine with this and other medication. So in conclusion, I've talked about bradyarrhythmia, especially bradycardia, talking about sinus node dysfunction, AV blocks, how to evaluate those patients, and just a little mention about what to do in treating them. So thank you for the audience you have given me. And if there are questions, we'll take the questions. Thank you very much.
Please, they should remember to fill the form.
So please don't forget, the link for the CME is in the chat box. So don't forget to fill that, to fill the form. Sorry, I took so much time talking. So I don't know if there are comments and questions from the people on the call. Question, comments. I hope I didn't confuse people with my ECGs. So question, comments, addition. So don't forget to fill the form in the link so that you can get your CME. And like I said, if you have patients with bradycardia that needs Holter ECG, you can send them to us. That can be done, and you get your feedback report from us. So, question. I can't see any question in the chat box, and nobody is no hand is raised. So I think it's either I've been able to explain well, or maybe I've confused, I've caused a lot of confusion. Okay, thank you for that. So next week, in the absence of any question or comment, next week will be another presentation, and I think we'll be looking at something related to AI and cardiovascular medicine. And so the exact topic will be circulated early next week, and we'll be glad if you can join us for that presentation. Thank you for staying till the end, and we'll see you next week. Don't forget to fill the CME form. See you next week. Have a good night. Thank you very much. Bye.